In this sketch, we'll cover disorders of the breast, starting with a brief review of breast anatomy. Then we'll explore a number of different benign breast lesions, and finish up with a discussion of galactorrhea, aka abnormal nipple discharge. As you might expect, breast lesions are much more common in women than in men, and usually take the form of palpable, sometimes painful nodules or masses. Fortunately, most of these lesions are benign. But keep in mind, breast cancer is the most common cancer in women, and second only to lung cancer as a cause of cancer-related death in women. Therefore, you'll evaluate plenty of suspicious breast lumps over the course of your career. So let's get you prepared. Well, what do we have here? Looks like we've left the hanging gardens of Bartholin and stumbled onto a backyard slip and slide party. This'll be fun, or interesting at the very least. The anatomy of the female breast affects its special function, production and expression of milk during lactation. Breast tissue is composed of both epithelial and stromal components. The epithelial components are the parts of the breast that actually participate in milk production and expression, and include the lobules, where milk is produced, and the lactiferous ducts that connect them to the nipple. At this fun backyard party of sorts, the epithelial components of the breast tissue are represented by the slip and slide. Check out the pool on this side of the slide. That's where all the water is coming from. Kinda looks like a breast lobule too, don't it? The slide itself represents a lactiferous duct, carrying all that water out to the open end, aka the nipple. While we're focusing a whole lot on the epithelial components of breast tissue, for good reason. That's where most of the pathology lies. It should be noted that the stroma, which is composed of fatty and fibrous connective tissue, makes up the majority of the breast volume in the non-lactating state. Turns out that breast pathology can arise from the stroma as well, which we'll get into in a moment. Alright, now that you're familiar with the anatomy of the breast, we'll use the bulk of this sketch to review benign breast lesions. Before we get started, however, our standard word of warning that you've heard 5 million times. Just because these disorders are benign doesn't make them harmless. The first benign breast disease we'll talk about is also one of the most common: mastitis. Mastitis, aka inflammation of the breast, is a condition in which a woman's breast becomes painful, swollen, and red. While mastitis can technically occur at any time, it's most commonly associated with breastfeeding, in which it's known as lactational mastitis. Lactational mastitis is quite common, affecting up to 10% of breastfeeding women. Our first contestant down the breast duct slip and slide is a mom with a baby in tow. Dangerous? Maybe. Illegal? Most likely. Fun? Ah, yeah. Let that red bathing suit remind you of the erythema that can be seen with mastitis. She's also sliding past those flames on the walls of the slip and slide. Our recurring sketchy symbol for inflammation, in this case, of the breast. As she cradles her baby's head against her breast, remember that breastfeeding, aka lactational mastitis, is the most common cause of mastitis. Whoa. Wait your turn, son. No need to pop the boob. Let that kid remind you that nipple trauma is the most likely inciting event leading to the development of mastitis. Lactational mastitis is most common early on, in the first few months of breastfeeding. Initially, engorgement of the breast occurs because of poor milk drainage, usually related to nipple trauma. Babies aren't very gentle, causing compression and obstruction of milk ducts. This blockage traps breast milk within the duct, eventually forming a little cyst known as a galactocele. Kind of like that growing puddle of water pooling around the mom. Since breast milk contains bacteria, if these ducts stay blocked up for longer than 24 hours, that bacteria can proliferate and cause infective lactational mastitis. When it comes to infective mastitis, Staph aureus is the most common culprit. At Sketchy, our recurring symbol for Staphylococcus aureus is the golden staff of, well, staph. Check it out, showering water all over the slip and slide. That steady stream of water should also remind you that the best way to treat lactational mastitis is to keep breastfeeding. Continued lactation and expression of milk helps to relieve the obstruction that caused the whole mess in the first place. As we mentioned previously, mastitis presents with breast pain, redness, and swelling. When infective mastitis develops, systemic symptoms such as fever and malaise will also manifest. The patient may also notice purulent nipple discharge. But don't let that discourage mom from continuing to breastfeed. In addition to breastfeeding, treatment of infective mastitis includes antibiotics as well. Of course, breastfeeding isn't the only reason lactiferous ducts can get obstructed. When it happens in the absence of breastfeeding or an infection, we call it mammary duct ectasia. Mammary duct ectasia occurs when lactiferous ducts are blocked by debris, rather than nipple trauma in lactational mastitis. Either way, the end result is somewhat similar. Inflammation, pain, lactiferous duct dilation, aka ectasia, and even fibrosis. Oh, right into those branches. Yeah, this slip and slide hasn't been used for a couple years now. It's always a rough ride for that first person down. Notice that the walls of the slide are also painted with those super cool flames to remind you that inflammation is also a feature of mammary duct ectasia. We've even made the walls of the slip and slide more dilated to reflect the dilated mammary ducts. Ew, those wet branches are leaking out nasty green stuff. That's to remind you of one of the classic symptoms of mammary duct ectasia: thick, aka inspissated, green nipple discharge. It can sometimes be seen on mammogram due to calcification of the inspissated secretion. Fortunately, duct ectasia often resolves spontaneously when the obstruction clears itself. Sorry, girl. Someone's got to break through those branches. Okay, enough with the breast duct clogs. Let's talk about what happens when you suffer traumatic injury to the breast. Fat necrosis of the breast is a benign condition that most commonly occurs as a result of breast trauma or surgery. Since we're dealing with adipose tissue, which is part of the stroma, our next participant in this unfortunate backyard circus is a rotund young gentleman who's taken a tumble onto a bunch of rocks. You're doing it wrong. His arm is also in a cast. This kid just can't catch a break, can he? Fat necrosis presents with breast pain and an irregular mass on exam. Just like those irregular rocks, that does not look comfortable. Fat necrosis is important to know because that resulting mass can often be confused with cancer. On imaging, you'll often see calcification, especially in older lesions. Fortunately, it's hard to write a test question about fat necrosis without mentioning a history of breast trauma or surgery, which should clue you into the diagnosis. In real life, though, many patients may not report a history of trauma, so sometimes it's necessary to biopsy these lesions to confirm the diagnosis. If a biopsy is taken, the only abnormality you should see on histology is necrotic adipose tissue surrounded by neutrophils and lipid-laden macrophages trying to clean up the mess. What you won't see is any evidence of cancer. Fat necrosis does not increase the risk of breast cancer, and no treatment is necessary. So far, we've gone over a number of relatively common benign disorders of the breast. Now let's cover the most common one of them all: fibrocystic change. Okay, it's kind of cheating, because fibrocystic change is a generic term for a number of different fibrous and cystic changes that can occur in the female breast. Still, fibrocystic change is the most common breast abnormality seen in premenopausal women, with more than half of women of reproductive age having fibrocystic change to some extent. Fibrocystic change is represented here by these two bushes being used to secretly stash some secret water balloons. Secretly. The umbrella term fibrocystic change can be divided into two groups: non-proliferative and proliferative breast lesions. We'll go over the pathology of each of these categories quickly, starting with non-proliferative changes, the more benign of the two groups. Non-proliferative lesions are the most common type of fibrocystic change, which is fortunate, since they're generally not associated with an increased risk of breast cancer. The most common non-proliferative breast lesions are breast cysts. The cysts that form are generally small and diffusely distributed throughout both breasts. Combined with fibrous stromal proliferation, this results in a breast that feels dense and lumpy on examination. On gross pathology, the breast cysts often appear blue on top, to the point where they're often referred to as blue dome cysts. Hence why the water balloons stashed in those bushes are blue. The fluid within breast cysts can often calcify, popping up as tiny little radiopacities on mammograms, kind of like those little white flowers. Beyond breast cysts, the other main non-proliferative breast lesion is known as papillary apocrine change, characterized by growth of ductal epithelial cells showing apocrine features. As in, they kind of look like apocrine gland cells, but they're not. They do, though, kind of have a granular appearance, emphasized here by this kid's spotty swim trunks. To help you remember that papillary apocrine change is a non-proliferative breast lesion, we've made that kid imitating an ape. Aping an ape, so to speak. That's it for non-proliferative lesions. Next, the proliferative fibrocystic changes, which include epithelial hyperplasia and sclerosing adenosis. Unlike non-proliferative lesions, proliferative breast lesions are associated with a small increased risk of breast cancer. Let's start with epithelial hyperplasia. Epithelial hyperplasia is exactly what it sounds like. The epithelial layer of breast tissue proliferates to such an extent that it starts taking over the lumen of mammary ducts or lobules. On histology, epithelial hyperplasia is characterized by breast ducts or lobules filled with benign-appearing cells that can fill up the entire lumen of the duct or lobule. Kind of like those benign bubbles filling up the kiddie pool. Usually, epithelial hyperplasia isn't a big deal. However, if atypia develops, these lesions can begin to look like low-grade ductal or lobular carcinoma in situ. Atypical epithelial hyperplasia is associated with a significantly increased risk of breast cancer, nearly similar to that of carcinoma in situ. To help you remember that atypia is associated with an increased risk of breast cancer, Just check out the kitty in the kiddie pool. She's wearing a very atypical bathing suit. It looks exactly like the pattern in the pool water, just darker with purple splotches. Some atypical nuclei, perhaps? She's also holding up a recurring sketchy symbol for malignancy, a cancer crab. The other major type of proliferative breast lesion is known as sclerosing adenosis. Let's see what it's all about. Sclerosing adenosis is a lobular lesion characterized by a proliferation of luminal spaces, aka adenosis, leading to an increase in small glands within the lobule. Just think of these sponges, filled with a bunch of tiny luminal holes. Kinda glandular, even. Not my favorite way to have a good time at a pool party, but hey, whatever wets your whistle, man. In addition to luminal proliferation, sclerosing adenosis is also characterized by increased fibrous tissue in the stroma, the sclerosing part of sclerosing adenosis. So we've brought in our recurring sketchy symbol for sclerosis, the sclerosis snake, disguising itself as a water hose and waiting to prey on small children. I say pick the chubby one, but hey, you do you. Like other usual proliferative breast lesions, sclerosing adenosis does confer a slightly increased risk for breast cancer, up to twice that of women without it. All right, moving away from the epithelium of the duct. It's time to hit up the stroma. It can get pretty wild out here on the patio, so get ready for the usual antics. The type of lesions we'll encounter are the benign breast tumors. First up, fibroadenoma. Fibroadenomas are most commonly found in young women between the ages of 15 and 35. Much like this pregnant lady. Rollerblading? Even if this were the early 90s, I'd still not recommend that. See how she's adding fibers to her little bouquet? That's fibroad in... Yeah, kind of fell apart at the end there. This pregnant lady, along with her earrings and necklace, is here to remind you that fibroadenomas are estrogen responsive, meaning their size can increase in times of elevated estrogen levels, like pregnancy, lactation, or just prior to ovulation, when estrogen levels are their highest. This fact also means that existing fibroadenomas can regress after menopause. Clinically, fibroadenomas are painless, well-defined, rubbery mobile masses. Just like those rollerblade wheels, you know? Round and defined, a little rubbery perhaps, and mobile, of course. And she's obviously happy, so, painless. Mobility is one of the most important features of a breast mass, BT dubs, because it generally rules out a malignant tumor. In younger women, fibroadenomas are usually discovered as a palpable mass on self-examination by the patient or on routine physical exam. In older patients, they're more often found incidentally on breast imaging. Fibroadenomas result from proliferation of both fibrous stroma and adenomatous ducts. As such, on histology, expect to see a benign-appearing myxoid stroma that encircles epithelium-lined glandular spaces. The stromal proliferation within the fibroadenoma can compress the glandular ducts, causing them to appear like slits on histology. This is shown on the concrete below. But just for extra emphasis, we've made her squeezing those stems, squeezing those ducts, as it were. As benign tumors, fibroadenomas are generally not associated with an increased risk of breast cancer. Moving on from young women to older women. Phylloides tumor. Phylloides tumors are rare benign fibroepithelial tumors of the breast that are capable of a wide range of behaviors. Unlike fibroadenomas, which tend to occur in younger women, phylloides tumors typically present later on, most commonly affecting women in their 40s. The term phylloides, which means leaf-like in Greek, describes the characteristic leafy, papillary projections that are seen on histologic examination. Clinically, phylloides tumors may be indistinguishable from fibroadenomas. They're also smooth, well-defined, painless mobile masses, with mobile once again being the critical term. Remember, if it moves, it's probably not carcinoma. Rocking the roller skates like it's 1969. In its least aggressive form, phylloides tumor is essentially the fibroadenoma of older women. However, some phylloides tumors can be quite aggressive, growing very large very quickly and metastasizing distantly. As a friendly reminder that phylloides tumors are capable of malignant behavior, we've placed a crabby rake over by our phylloides tree. Fortunately, most phylloides tumors are not super aggressive, and the majority of patients are cured by surgery. All right, let's finish up this sketch with a few conditions that cause abnormal nipple discharge. Remember, nipple discharge is pathologic if it's unilateral, persistent, or bloody. Let's start with bloody. Intraductal papillomas are rare benign papillary tumors that grow from the wall of a lactiferous duct into its lumen, just like this papillary bush poking out into the lumen of the slip and slide. Oh, man. First bleeder of the day. They're the most common cause of bloody nipple discharge. So if you see blood, think intraductal papilloma. The bloody nipple discharge associated with intraductal papilloma results from twisting of the vascular stalk connecting the papilloma to the wall of the duct, much like the red water hose that's gotten all twisted around the base of the papillary bush. On histology, look for papillary cell projections with a fibrovascular connective tissue core. Other than bloody discharge, affected patients typically have no other symptoms or even a mass to be palpated. Intraductal papillomas are themselves benign. However, they can hide in areas of cellular atypia or even ductal carcinoma in situ, which do carry an increased risk of malignant transformation. Because of this risk, intraductal papillomas are all surgically removed, which also fixes the whole bloody nipple discharge problem. Okay, enough about bloody nipple discharge. Let's move on to milky. Abnormal milk letdown is known as galactorrhea, and it can be associated with a number of pathologic conditions. Let's quickly go through them before we finish up. Officially, galactorrhea is defined as bilateral milky discharge unrelated to breastfeeding. One of the most obvious causes of galactorrhea, of course, is mechanical stimulation of the nipple, just like what the kid is doing to that bottle. Galactorrhea can also be caused by elevated prolactin levels, i.e. hyperprolactinemia. Hyperprolactinemia may be secondary to a prolactinoma, which is a tumor of the lactotroph cells in the anterior pituitary, as depicted by this overload of prolactin baby bottles stuffed into that pituitary diaper bag. For more info on prolactinomas, check out our anterior pituitary disorder sketch. Prolactinomas are pretty rare, actually. Instead, hyperprolactinemia is more often an adverse effect of medications that inhibit dopamine. For example, antipsychotics with D2 dopamine receptor antagonist activity. Dopamine normally inhibits the action of lactotrophs of the anterior pituitary. So inhibiting an inhibitor means increased prolactin secretion. Yep, that's a double negative. D2 blockers are symbolized by that double break in the double dope rope. For more details on antipsychotics, check out our antipsychotics sketchy farm sketches. So we've taken a few lumps. Some of them inflammatory, like mastitis and duct ectasia. Some of them painful, like mastitis, ectasia, and non-proliferative fibrocystic change. Some of them calcified, like duct ectasia, fat necrosis, and non-proliferative fibrocystic change. And some of them dischargy, like infective mastitis, ectasia, and intraductal papilloma. Some of these even have a small risk for cancer, like epithelial hyperplasia, sclerosing adenosis, phylloides tumor, and intraductal papilloma. Next up, real malignant potential. It's time to talk about breast cancer.